This episode of JNM Podcast is sponsored by GE Healthcare.
Hello, my name is Ken Herrmann. I'm a nuclear medicine physician based in Essen, in Germany, and I welcome you to the first JNM podcast in 2025. We have a super exciting topic. We're going to talk about cardiovascular perfusion imaging. And as you all know, this is not my strong suit. That's why I'm very happy to have a fantastic co-moderator next to me, Professor Frank Bengel. He's a chair of nuclear medicine in Hanover, Germany. He also serves as the Dean of Research in Hanover. And a fun fact, he was one of my first attendings when I started my residency quite a few years back home in Munich. Welcome, Frank.
Thanks, Ken.
In addition to Frank, we have, of course, also two additional experts. One of them is Professor Sharmila Dorbala. She holds the prestigious position of Professor of Radiology, and she also serves as a Director of Nuclear Cardiology at Brigham and Women's Hospital. She initially started her medical career actually in India, and then moved to the US, where she did her residency in internal medicine and specialized in fellowships in nuclear cardiology and cardiovascular diseases. Welcome, Sharmila.
Thank you, Ken. Happy to be here.
In addition to these two excellent editors of the Journal of Nuclear Medicine, we also have an outside JNM expert with us, Professor Jamshid Maddahi. He is currently a clinical professor of molecular medical pharmacology, but also of medicine. And he also serves as director of the Biomedical Imaging Institute. In addition to this, and this I think underlines how impressive it is, I saw that you started your nuclear cardiology research in 1977, which is pretty much the year I was born. Welcome, Jamshid.
Thank you.
To kick it off, Frank, I would like to ask you a little bit, where are we currently in the field of perfusion imaging? Also, tell us a little bit about advantages and disadvantages about PET and SPECT.
Yeah, thanks, Ken. Well, that's of course a very broad topic, so I'm going to try to be precise. I think the role of myocardial ischemia imaging is still very strong worldwide, given the fact that cardiac CT is pushing into the field where you will have strong information about coronary morphology. This probably even emphasizes the need for detecting myocardial ischemia as a consequence of changes of coronary anatomy even more. So we expect to have more and a growing need for ischemia detection. Probably also we expect to have a need for more accurate tests that give more precise quantitative and regional information. And I think this is also where PET is going to be highly relevant, because PET, when compared to SPECT, has advantages with regards to spatial resolution, with regards to detection accuracy, and with other regards, especially with regards to the tracers that we can use for imaging. And I think this is where Flurpiridaz as a new tracer comes in.
So you already built perfect bridge to my next question is, Jamshid, you are Mr. Flurpiridaz. Can you tell us a little bit about the tracer and where it comes from and how it got to where we currently are?
Well, Flurpiridaz has basically the advantage of it is because of an F-18 label that allows production of the tracer at commercial and regional cyclotrons and distribution to the centers that have a PET imaging device and have patients. And that is quite an important advantage, because when we look at the statistics in the United States, SPECT imaging is approximately, the volume is about 5 to 6 million studies a year. But when we look at the PET, all of PET is about 2.2 million, and only 7% of it is for myocardial perfusion imaging. So we're talking about 150,000 only. And the reason for this discrepancy, in spite of superiority of PET, is that the current isotopes are not readily available. They require an on-site cyclotron or expensive generators such as rubidium. And with an F-18 label, now we can take advantage of the regional cyclotrons that have been developed over the past several decades for FDG, for instance, in order to produce the isotope and deliver to the hospitals. Within the US, there are, I would say, more than 90% of the population have access to these regional cyclotrons and to PET scanners. So you can imagine that how this can actually influence the widespread use of PET myocardial perfusion imaging. The second advantage of the F-18 label is that because of this long half-life, we can perform exercise imaging along with PET myocardial perfusion imaging. And beyond that, the flurpiridaz itself is a molecule that has a very high myocardial uptake, and therefore it allows better delineation of the myocardium and ischemic areas. And all of this has been actually demonstrated in the phase 3 trial that image quality is superior and the confidence of interpretation is superior to SPECT. And also the ischemic defect is much larger with flurpiridaz than with SPECT imaging.
Thank you, Jamshid. Sharmila, so you already have some practical experience in contrast to many people from us in Europe. Tell us a little about the practical specifics about this test.
Yeah, that's a great question. So when I think about perfusion imaging with PET, the current landscape is rubidium, ammonia, and now you have flurpiridaz added. And we have experience with both rubidium and ammonia. So in my opinion, what I feel the big advantage is the long half-life of flurpiridaz makes it somewhat similar protocols-wise to what we are familiar with, technetium, 99M, sestamib, or tetrafosmin with MIBI studies. So what I mean by that is with rubidium and ammonia, because of the short half-life, we are somewhat restricted to vasodilator and quick imaging right after injection. And then, of course, with ammonia, you can do exercise as well as vasodilator. But with this tracer, I think the advantage is the workflow could be just like sestamib. You could stress the patient in the stress lab, inject the tracer, put them on the scanner, and take a picture. Or you could have a hybrid where you want to quantify blood flow. So you have the patient on the PET scanner, you do a list mode acquisition, you have your static, dynamic, gated images as with the standard perfusion PET tracers. So this really makes it easy from a technologist perspective because there's no pressure. More importantly, I think the protocols can also be like sestamib, low dose, high dose. So what is recommended in the package insert currently is 2.5 to 3 millicuries of flurpiridaz for the first scan. And if you do the same day protocol, then the second scan could be 6 to 6.5 for vasodilator, which is most likely going to be the most commonly used because we want flow quantitation. If in some cases you need exercise, then the second dose with exercise is more like 9 to 9.5 millicuries. That's what's recommended. And the time between injections, because of the shine through from the initial injection, what's recommended in the package insert is about 60 minutes between the injections for exercise and 30 minutes for adenosine. And I think Dr. Maddahi can add here, but I believe this is based on some biodistribution studies which showed that the percent injected dose in the myocardium within the first 17 minutes was much lower with exercise than vasodilator. So that's why they made a recommendation to wait longer, the delay of 60 with exercise and 30 with vasodilator. So Jamshid, what do you think the final clinical protocol is going to be in practice?
Well, I think that in practice, we can actually make the time difference shorter. We have used the rest image subtraction technique, the background subtraction, to remove the spillover from the rest to the stress image. That is one method that can be used. I'm looking at the kinetic data that is not published, but it shows that even with 15 to 20 minute wait period between the rest and stress, we would be okay with pharmacologic stress testing. I think that the challenge of exercise will remain, as you pointed out, that the uptake percent, the dose uptake by the myocardium is lower with exercise because of the uptake by peripheral muscles. And therefore, I think that an hour is currently the recommendation.
Yeah, so I think based on what you're telling me, I think if we need to wait even 15, 20 minutes, so I can think of a protocol where the patient has to be taken off the table because we are under high pressure these days to have lab throughput with oncology cases competing with cardiology cases. So one difference I see between rubidium protocols and this would be probably we need 2 CTs, at least for some PET scanners, where the first study is technically closed, the patient's position again, and you need a second CT for attenuation correction. Is that what you're...
Yeah, what I can add here is that when we were in the trial patients, we never took patients off the of the scanner. And I think getting a second CT is always a good idea. It doesn't take much time, and it actually helps removing some of the misregistration artifacts at the end of the study.
I could maybe just comment on the protocol, since there is a recommendation for a protocol from the package insert, but this is based on the clinical trials. However, I do think that there is a lot of room for development, and we could certainly explore other acquisition protocols. And just bringing in another issue is, of course, many people who do SPECT are used to doing a stress-only or stress-first approach. This is a bit more challenging with Flurpiridaz, since the extraction is almost linear to the flow, and the flow at stress is much higher than at rest. You will have a much stronger myocardial signal when you do the stress study first. So it's basically, and I don't know, I would ask Jamshid or Sharmila what you think, but I think doing a stress first approach with Flurpiridaz will be a challenge unless you do a stress only and maybe get rid of the rest study in general.
Well, I can add that because of a higher extraction fraction with exercise, then we would use the low dose initially with stress. And by using low dose with stress, we know that the image quality would be perfect, would be excellent, because already we have done studies that we have gone down to 1 millicurie dose with the rest injection, and the image quality was acceptable. But I think with the 2 to 2.5 and stress imaging, I think that we will definitely have a very good quality image. So we could perhaps reverse the rest stress protocol to stress rest protocol using low dose for stress, and for the resting study, then we would do a higher dose. Now the question remains that how much wait period between the two studies should be. We know statistically that more than, at least in the United States, 80% of patients who are imaged end up being normal. So I think that here, with the advantage of having an attenuation correction, if you do stress first, we could probably end the study right there in 80% of the patients by use of attenuation correction and the higher confidence that this study is normal and we don't have to go to the resting study.
Yeah, my thought on that, it's actually a very interesting thought that Frank brings up. I was thinking if you did stress first, let's say there's a mild defect, and I guess Frank is saying the defect may be challenging because there's so much extraction, probably even in the defect zone. But I thought the shine through will be less of an issue if you started with stress and then added the rest on top, because there's a defect. So there'll be less shine through in the defect zone, technically.
Yeah, good point. I think these kind of things we still need to learn while we practice. And I think if you want to give out a recommendation to somebody who starts with the tracer from scratch, it's probably useful to just stick to what is in the package insert and then work from there and see how it can be improved.
So it is rest, stress, or 2-day protocol as per the package insert.
Right. So from a JNM perspective, I see that there's still a lot of room for more research, even post-approval, which again hopefully brings a lot of interesting papers to the Journal of Nuclear Medicine. This being said, we mentioned already a little bit the clinical studies. Jamshid, you were one of the key drivers of these studies. Can you give a very quick summary of, especially of the phase 3 study? What was the result? What was shown there?
The phase 3 study consisted of 2 studies. One of the phase 3 number 1 and number 2. I'll focus on the number 2 publication that came out about 2 years ago. And it showed that the primary endpoint was that Flurpiridaz would meet a certain threshold for detection of coronary artery disease as compared to coronary angiography, quantitative coronary angiography, and it did meet the criteria. The second goal was to compare it to SPECT, and that in that comparison, it did show that it is ROC curves show that overall it is the ROC curve shows a better performance, a higher performance, significantly higher performance of PET compared to SPECT. And what was very interesting and important is that in a certain subgroups of patients, PET performance was significantly better than SPECT. And those patient subsets were females and obese patients, and also in diabetic patients. And then the study focused on comparison of the image quality that the PET showed a higher percentage of studies being called excellent as compared to SPECT, and also the higher confidence of interpretation, meaning that there were a higher percentage of studies that were called definitely normal or definitely abnormal by PET as compared to SPECT. And also the defect size was almost double the size in terms of severity and extent as compared to SPECT. And more importantly, I think that there are two issues that I want to bring up. One is the safety that has been shown in phase 1, phase 2, and both phase 3 studies that the tracer is safe and well tolerated. And an important comparison with SPECT is the radiation exposure. In the phase 3 studies, the average radiation exposure of patients with SPECT was slightly over 12 millisieverts, but with PET was about 6 millisieverts, which is half of what the SPECT can do. And what happened in addition to that was that when we have done some studies that are not yet published, but with certain advancement in processing, we can actually get the dose down to about 2 to 2.5 millisieverts, the exposure to the patient. So that I consider to be a major advancement, that we are reducing the amount of radiation exposure of patients with the Flurpiridaz method.
And in the pre-discussion, we already mentioned it in phase 3, mainly analog PET scanners were used. Potentially, there's even more room for improvement with the now widely available digital scanners. This being said, you kind of watered my mouth already a little bit by saying there are 5 million SPECT studies. So how many studies will now really be in the future Flurpiridaz PET? So Sharmila, what is your prediction there for the US nuclear medicine people?
The predictions are challenging, but if you ask me for my wish list, comparing the quality of PET versus SPECT, I would like to see a future where all of radionuclide perfusion imaging is PET perfusion imaging. I think this tracer opens up the possibility, of course, cost aside and all of that. The reason I say that is all your exercise specs can, in theory, be an exercise Flurpiridaz stress-only PET, right? And all our vasodilators currently, we preferentially do PET anyway. So the US practice, one more difference. We have cardiology practices and nuclear medicine practices, right? We have high volume centers and low volume centers. What this tracer does relative to previous existing tracers, it allows the low volume centers to join perfusion PET. It makes it a little challenging for the cardiology only practices to switch, because now they need these lead line holding rooms for these patients, which they may or may not have. Especially if they're using rubidium, they probably don't have a waiting area for the injected patients. So it really goes site by site, and primarily these are the considerations probably for the US, but Jamshid may add some more.
Yeah, I think practically, I believe that we will never we will not eliminate SPECT or rubidium imaging. I think the high volume rubidium centers will probably continue to do rubidium. I think that the SPECT will be continues at least for the next several years, because the transition from SPECT to PET takes some time. But I would predict, comparing to the volume that we are doing currently, about 150,000 myocardial perfusion PET studies per year, I think that we will get up to probably 10 times as many. We get up to 1 million, 1.5 million to 2 million studies. And that would be either at the expense of doing less SPECT, or, as you said, by basically opening up the opportunity for the low volume centers to do Flurpiridaz imaging that they weren't doing before. So I think that the future is bright, but I'm not sure how long it will take to replace everything, as you said, ideally. I think that may never happen, but it would be a significant increase in the volume of PET images.
Or we may get better SPECT tracers for perfusion, right?
Yeah, I think one shouldn't underestimate how convincing and how easy to I shouldn't say easy to interpret, but easy to present those Flurpiridaz PET scans are as compared to many other myocardial perfusion imaging technologies. So that by itself is hopefully going to be an advantage, which will cause in something like an avalanche effect. You start doing a little bit of it, and then you keep doing even more, simply also because the people that you collaborate with will be more and more convinced by the test.
Right. I would like to add that I think that this higher image resolution comes with some caution in terms of interpretation of the studies. Number one, for instance, apical thinning appears very common with a tracer, while we don't see it with other tracers. So we have to learn how to interpret and not overread apical thinning as being defect, especially that we do gated studies. We can always see that there's a perfect motion in that area, and therefore that does not represent scar tissue. The other issue to keep in mind is that the higher resolution increases the chance of movement artifacts and misregistration of PET and CT. So we became actually very aware of this when we were doing dynamic studies, that we saw very often patient movement occurs, and that is not because the patient moves. It is like the upward creep of the heart that we have seen with exercise patients during pharmacologic stress testing. So currently there are several versions of softwares available to actually correct for motion. And that is one of the things that I wanted to emphasize, that we need to focus on some of the sources of artifact with this high resolution tracer.
But isn't it a possibility that you could repeat the scan if the patient physically moved? Let's say patient was coughing or sneezing.
Right. No, if it is a patient movement, in our experience, patient movement is much less frequent than the motion that occurs with pharmacologic stress testing, that the patient's actually heart moves. And that movement is because of a deep breathing of the patient, and then the position of the diaphragm being lower in the beginning and then gradually coming up. And there's a gradual movement, like the upward creep that we had seen in patients with high level of exercise that occurs with pharmacologic stress testing. So I think that motion correction will become an integral part of evaluating or processing images with this tracer.
So this all sounds super exciting. 2.5 million oncology scans in the US, plus 1.5 million now cardiac scans. Now, how is it we have quite a few listeners also from outside the US. Frank, how are the market predictions for Europe as overall outside of the US?
Yeah, I don't have these exact numbers for Europe. I'm impressed that Jamshid does have all these numbers, but as we know, I think in Europe, much of the PET market is driven by oncology applications. So most of the PET labs have very high throughput oncology patient procedures, and I think it has been touched on that already. I think Flurpiridaz is probably perfect to match into this oncology high throughput situation. You could easily, for example, since you can do single dose scans, basically you can order the doses for your patients, and then you don't need to worry about doing multiple scans one after the other, as you would have to do if you ordered a rubidium generator, for example. So you could, for example, use that early window in the morning where you are still waiting for your oncology patients to go through the uptake phase of the tracer, to do maybe 1 or 2 myocardial perfusion studies. And I think that's a way how this would perfectly fit into a low throughput, mostly oncology focused scenario, which is mostly, I think, going to be the case in Europe. There's a couple of countries where there's a lot of high throughput PET cardiac centers, but not that many countries. And my hope would be that there is a good market for Flurpiridaz across Europe if this is, let's say, promoted well enough, trained well enough, and at the same time is also price-wise in a range where people will not stay away from the tracer.
You're mentioning very good points, and in every good paper, you always end up with the limitation section. So it's also in our exciting podcast. I, of course, also want to ask you, the 3 giants of cardiovascular imaging, what are potential challenges for the widespread use of Flurpiridaz? And maybe, Jamshid, we start with you because, and then, yeah.
I think I can't see much of a challenge. I think that one potential challenge would be the cost. It depends on how it is placed in the market and what price tag it has. But since the volume increase is going to be gradual and will take years before it reaches the several million that the SPECT studies are being done, I think that that price challenge is very difficult to predict. But I would say that is the only thing I can think of is the price challenge. And the other thing is that the challenge is that many institutions that are currently have PET scanners, they're using the PET scanners for oncology studies. And I think that soon they will realize that they have to switch to actually getting a dedicated camera for cardiac studies. And they have to switch away from SPECT imaging. So that transition is a financial challenge, but I think that we have seen that happen in the past with planar imaging going to SPECT imaging, and then from SPECT imaging going to PET imaging for non-cardiac studies. And I think that these challenges exist, but they will be met, in my opinion.
Sharmila.
Yeah, so I think one of the challenges, I fully agree with Jamshid, no major challenges, but I think for high volume labs, I'm still not clear in my mind. For example, we are currently doing 12 to 14 PET scans, perfusion studies every day. Until we work with this tracer, I don't know if I can get 12 to 14 a day with this tracer. So we'll have to kind of get creative with the protocol. So that's one challenge, to develop the protocols, how to use it. Then, of course, radiation for the technical staff, as opposed to rubidium, maybe there's a little bit more exposure with F-18. You deal with this all the time with your oncology cases. So staff have to be trained to appropriately use this radio tracer, probably. And then, of course, getting organized on how to do this. It's possible that we set 1 hour aside. You do 5 stress tests in the treadmill lab or in the stress lab and bring one by one, or you do 5 vasodilators back to back, then set 1 more hour later for resting imaging. So I think developing the protocols for each lab, that would be an immediate challenge.
And maybe on top, one should add that Jamshid has mentioned that briefly already, is I do think that training of reading physicians is going to be very important, simply because a Flurpiridaz PET study will not be the same as a myocardial perfusion SPECT study, and probably even not be the same as a rubidium or ammonia study, simply because it's a different tracer. And it gives you so much better, I would say better image quality, that you have to be cautious not to overinterpret these images. And then at the same time, there's this challenge. I mean, we know it depends on what kind of patients you see. If you see low pretest likelihood patients, you don't want to overinterpret them. But then at the same time, we also need to learn how to interpret them correctly in patients with advanced disease, where you want to make sure that you give the right interpretation when it comes to extent of the disease to the clinicians. I think these kind of things are important in the beginning in order to increase the acceptance. And at the same time, this will be another area where we will need to learn, because advanced disease has not been included in the clinical trials to be correct, right? So this is another thing that we need to learn as we move ahead with the tracer.
Well, Sharmila, your point with the lack of access to cameras is very important. Is there all of a sudden room for dedicated cardiac PET cameras, or?
I may make a comment. I definitely believe so. I think that when we started research on the very first patient that we injected with Flurpiridaz in the US, I was very, very excited about it. And the immediate thought was that why not have a dedicated cardiac camera? Spoke the idea with Dr. Phelps at the time. And actually, it seems like that the very price conscious type of cameras can be developed that are cardiac only, and those cameras, I think that there is room for them, for this type of cameras to be developed in the future.
Yeah, what about Jamshid? Just one last question. With the blood flow values, do we have normal limits for this tracer developed yet? Or?
Yes, we do. I mean, we have published, depending on what software you use. I mean, one of the goals that I emphasized in the early phases was to develop software with all the major softwares that do quantitation, and then all three major softwares, the Sintermet, the Emory Toolbox basically is part of that, and also with Cedars-Sinai program and the Michigan program, they all have developed software for quantitation of myocardial perfusion. And we have a paper that has been submitted for publication that compares all three different softwares to one another, and actually shows very interestingly that they're very comparable in their numbers. So there would be published numbers for the normal limits. The normal limits are higher than rubidium just because of a higher extraction fraction. But there are numbers that will be published for each one of the software that soon, very soon. So therefore, all the data is available. Yes.
I can add to that, Sharmila, based on our personal experience. We're doing Flurpiridaz studies in Hanover for a while now, and again, I would agree with Jamshid. The quantitative flow, I do think, is a strength of this tracer, as the image quality is so great that the quantification basically works automatically. However, it has already been mentioned that we may know our normal values with the new method, which might be higher than with other tracers, but we don't know a whole lot in advanced disease. Because again, in that setting, the values that we get may also differ from the other tracers based on the tracer kinetics. So practical reality is, and I've been discussing this with a couple of colleagues, is you may end up getting quite, let's say, flow reserve values that are unusually high in patients with advanced disease, compared to the flow reserves that you get with rubidium or other tracers. And I think that's a word of caution. It's something that we need to investigate more. What does that mean for the patient?
Yeah, I think that along those comments, I would say that yes, we need to use tracer-specific normal limits. We cannot use rubidium's normal limits for this. It has, as I said, that there will be publication that shows the normal limits for each one of the tracers, each one of the software programs, that what the normal limits are. And I would add also one very interesting observation was that when we looked at the high quality images, as you pointed out, that we are able now to do segmental analysis of myocardial flow reserve, meaning that in the 17 segment model, we can actually obtain values for each one of the 17 segments. And in a publication from from our institution, the first authored by Dr. Packard, showed that segmental analysis of myocardial flow reserve is actually superior to global or the regional type of flow reserve measurement. So I think that there is room for increased sensitivity, I would say, for detecting disease using segmental analysis.
So we are hitting the 33-minute mark. So thank you very, very much for joining. This was a very fascinating and entertaining discussion. Before we close, however, I want to also mention that Jamshid, you are based in Los Angeles, and we know that this is currently a very difficult time. Two of our co-editors of the Journal of Nuclear Medicine have lost their house, and I think it's also very important to appreciate that that we are not affected, and also think of the people who are affected. So yes. Thank you very much for joining. Thank you very much for tuning in, and it was fantastic. Thank you very much, all three of you. Thank you very much, Sharmila. Thank you, Jamshid, and of course, thank you, Frank.
Thanks.
Thank you very much.
Thanks for watching, and thanks to GE Healthcare for sponsoring this episode. Please remember to like and subscribe.